Okay, next slide, please. As we begin today's session, it is important to situate ourselves and reflect on the land we each reside on. We recognize that our work and the work of our members takes place on traditional Indigenous territories across Ontario. We also wish to acknowledge that the RNAO head office is located on the traditional and unceded territory of the Huron-Wendat, Haudenosaunee, and the territory of the Mississaugas of the Credit. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, which is an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We also acknowledge that Toronto is covered by Treaty 13 under the Toronto Purchase Agreement with the Mississaugas of the Credit. Today, this land is still the home to many First Nations, Inuit, and Métis people from across Turtle Island, and we are grateful to have the opportunity to work on this territory. By personally making a land acknowledgement, you are taking part in an act of reconciliation, honoring the land and Indigenous heritage which dates back more than 10,000 years. We encourage you to learn about the land you reside on and the treaties that are attached to it. Land acknowledgements are an act of reconciliation, and we must all do our part. I will now pass it over to Brenda, who will introduce the team involved in this BPG.
Hi, and I'm very excited for today. It's, the title of the day for preventing pressure injuries. So we're delighted to have our co-chair of the expert panel, Dr. Corey Hersham, and he will present today. And along with Dr. Dimitri Beacom, who is not here today, played a crucial role in the development of this guideline. In addition to hearing from an expert panel member during today's session, you will also hear from members of the RNAO team who are involved in supporting the development, implementation, and evaluation of the guideline. So my name is Brenda Stade. I'm a guideline methodologist at RNAO, and I'm currently joined today by my colleagues Glynis Gittins. She's a guideline development project coordinator. She'll help with all this together with Lindsay and Catherine Wallace, Senior Management of Implementation Science, and Christina Madero, Senior Management Evaluation and Monitoring. So I'll start off with our objectives. So we're going to discuss pressure injuries and the value of using this PPG to improve outcomes and quality of care. Then we'll provide an overview of the BPG, purpose and scope, guideline development process, good practice statements, and recommendations. And then following a short break, the RNAO team will discuss next steps for kickstarting implementation and evaluation of the BPG in practice settings. There will also be time for questions and answers at the end of the webinar. And I'll now start off today's presentation by sharing about the Registered Nurses Association of Ontario. So before we begin, we'd like to give a bit of a background on RNAO. RNAO is the professional organization representing RNs, NPs, and nursing students in Ontario. We are the strong, credible force that leads the nursing profession to influence and promote healthy public policy and clinical excellence. A signature program of RNAO is an International Affairs and Best Practice Guideline Center, which houses the Best Practice Guideline Program. RNAO Best Practice Guidelines are actively implemented across Canada as well as internationally through partnerships with our Best Practice Spotlight organizations, or the BPSOs. The Health Policy Program is another core pillar of RNAO as well. And this work is funded primarily by the Government of Ontario. All work produced by RNAO is editorially independent from its funding source. So the RNAO BPG program was launched in 1999. It's quite a long time ago, it's 25 years. And it is funded by the Government of Ontario. Sorry, if you can't hear me or anything, just let us know. The purpose is to develop, disseminate, and actively support the update and sustainability of evidence-based clinical healthy work environment and systems BPGs, and to evaluate their impact on patient, organizational, and health system outcomes. We've currently developed over 50 best practice guidelines and a variety of implementation toolkits to support the implementation process. So here on the slide, you'll see RNAO's integrated BPG model that includes 3 integrated pillars of guideline development: guideline dissemination, implementation and sustainability, and guideline monitoring and evaluation. These pillars inform one another and work in sync to improve outcomes for persons receiving care and providers, organizations, and systems. During this webinar, we will focus on all 3 pillars as they relate to developing, implementing, and evaluating the clinical practice of the pressure injury BPG. It's also important to mention that best practice spotlight organizations, or BPSOs, who enter into formal partnerships to implement the BPGs are located across Ontario, Canada, and internationally. And over the past 2 decades, the BPSO program was spread to include over 1,000 BPSOs globally. So that's amazing. Next slide. So this is the slide that's stood on the top of the of all the slides you saw just prior. So the RNAO's integrated BPG model contains 3 pillars, and the pillar at the top of the slide was the BPG development. And it outlines the guideline development process, and you'll see like it goes from topic selection and goes to 5-year guideline review. But this slide, we're going to go over this in a little bit more detail later, and it'll look slightly different, but I'll point that out to you. And now I would like to turn this over to Corey.
Perfect. Thanks so much, Brenda. And thank you everybody for joining us today. My name is Corey Hershap. I work as a wound and ostomy clinical nurse specialist at Royal Victoria Regional Health Centre in Barrie, Ontario, as well as the current president of Nurses Specialized in Wound Ostomy Continence Canada. So I have the pleasure of co-chairing this best practice guideline with Dr. Dimitri Beekman, who wasn't able to join us today. But I'm just going to start off by overviewing a little bit about pressure injuries, and then I'm going to turn it back to Brenda, and then I'll have the opportunity to talk to you a bit about the recommendations that were actually made in the guideline that we're going to be reviewing today. So a little bit about pressure injuries and the background for this best practice guideline. Pressure injuries are localized damage to the skin and underlying tissues which result from pressure or pressure in combination with shear. And now these usually occur over an area of bony prominence, such as the heels, the elbows, areas like the sacrum, but they can also be related to medical devices and externalized pressure, which can lead to tissue breakdown. Some of the most common areas, as you can see, are the sacrum, the heels, and areas like the trochanter. And you can see a number of risk factors here on the slide that can impact pressure injury formation. And if we wanted to skip to the next slide, you'll see here that pressure injuries can have a significant impact on patient quality of life. And you can see that over time between 1990 and 2017, pressure injury incidence has remained relatively stable. In other words, there has been minimal actual change and improvement over time in terms of how we're managing pressure injuries and reducing their impact. You can see that they have a very significant financial impact. That's coming from a US study. The amount of funding that we actually spend in Canada every year on wound management is significant, upwards of $11 billion. Now, we don't have the specific numbers as the US do just for pressure injuries, but considering the number of pressure injuries to other wound types, it's quite significant in amount. Now, if you're looking for some updated statistics specifically for Ontario, unfortunately, they are quite lacking in terms of availability. Some of the most recent being provided through Health Quality Ontario, that's about 2014, 2015 data. And those can be found if you're looking for the Health Quality Ontario standards of practice for pressure injuries. So I would encourage you, if you're looking for that extra information, to take a look at that data. Now, some other information about pressure injuries. There have been studies that found that pressure injuries led to reduced autonomy, increased sense of insecurity, and decreased mental well being, with high depression scores found when you look at associations between decreased comfort, decreased enjoyment, food and activities. Um, and pain in regards to pressure injury formation. So, huge impacts both in terms of the healthcare system, but also that patient specific information. So, with that said, I will turn it over to Brenda to talk a little bit about the pressure injury guideline and how it was developed.
Thank you, Corey. You talk nice and I like your ease of speaking. I'm a little rushed, I think. Purpose and scope. So the purpose is to provide nurses, members of the interprofessional team, and other collaborators, including administrators and policymakers, with evidence-based recommendations for risk assessment, prevention, and treatment of pressure injuries. This guideline recognizes that people at risk of developing pressure injuries are people who have developed pressure injuries, and their caregivers are expert in their health and decision making. And the next one. Oh, you did. Sorry. So scope. This BPG provides evidence-based recommendations for nurses and the interprofessional team and persons and their caregivers across all care settings and sectors. The recommendations address the prevention of pressure injuries for at-risk people and the assessment and management of those living with pressure injuries. Overall, the scope includes all domains of nursing practice, all healthcare settings and sectors, all populations across the lifespan. So there's pediatrics, adult, and older adult, including their caregiver chosen family, and all types of pressure injuries, including medical device related pressure injuries. So as Corey had explained. And this slide is similar to the little pillar I showed you on top. So basically it's a high level BPG development program. So the slide shows where we were in the development process, and from starting the pre-development work of this guideline back in 2022, we've come a long way. We've completed topic selection and formed a panel of experts who were involved in determining the purpose, scope, and research questions for the guideline. The RNAO team then completed the systematic reviews and made the summary documents to share with the expert panel, who developed recommendations and good practice statements to be included in the BPG. Then the RNAO drafted the BPG, which was reviewed by the expert panel and the external reviewers. Finally, the BPG was published, and today starts the day of trying to disseminate the information. So the guideline that could not have been created without the expert panel who contributed their knowledge and expertise to the development of this resource. The panel included persons with lived experience and was interprofessional in composition. It comprised individuals with experience in clinical practice, education, research, and policy across a range of health and social science organization, academic institution, practice areas, and sectors. These experts shared their insight on supporting and caring for persons and their support network. And on this slide, you'll see the names of the expert panel, many who are on the call today, or we hope. So you see Dr. Dimitri's name, Dr. Corey's name highlighted, but then all the other people. And there's about 15 here. Dr. Kevin Wu, Dr. Linda Norton, and a lot of wonderful people. The panel played a key role in determining the BPG purpose, scope, and recommendation questions, and they provided feedback at various stages throughout the guideline development on the BPG indicators, implementation tips, and supporting resources. As part of the guideline development, the draft guideline was also reviewed by end users. And in this case, the guideline was reviewed by 73 external reviewers from within Canada and internationally, which further enhanced the rigor of the guideline. Their names can be found within the guideline. And before we move forward, I'd like to acknowledge the entire RNAO team that was involved in bringing this guideline to life. So Amy Burke was the guideline development lead senior manager. So who is on leave and just had a little boy named Charlie. She was the guideline development, the lead. So she actually taught me how to actually do these BPGs, and because this is my very first BPG. And then Glynis Gittens is a guideline development project coordinator, and she just helps to put everything together. And then we're supported by Nafsin Nissim, Associate Director of Guideline Development, who's very helpful and very helpful. And then she wouldn't let me put her name on, but I'm telling you, Lindsay Howard, who's operating the slides today, did so much in helping getting this ready at the end for publication. There was also many other RNAO team members that contribute to the development of the BPG, including members of the implementation science team, and you'll get to listen to Catherine, monitoring and evaluation team, and you'll get to listen to Christina, and then executive stewardship. And I'd now like to speak about the guideline methodology. So it's important to know that we develop our guidelines. We use grading of recommendations, assessment, development, and evaluation, grade, methods to support our rigorous guideline development process. Grade is in line with the international guideline standard and is used by other organizations such as the World Health Organization. So again, to grade methodology, this guideline contains both good practice statements and recommendations. We'll walk through the difference between both statements, but what is important to remember is that they are both action-oriented statements based on evidence that make the guidelines something that can be implemented. They follow the same process for implementation. So for good practice statements, which would be on your left, good practice statements are actions that can be done in practice. They may be seen as common sense actions, but they are not always happening in practice. Hence the need to reinforce them in the guideline. We have certainty that benefits outweigh the harms, and a systematic review is not needed to determine this. In addition, researchers may no longer be conducting studies on the topic as the benefits are well known, or the alternative to the action may be unethical, so it would not make sense to study it. Good practice statements do not receive a rating of strong or conditional, but they should nevertheless be interpreted as strong recommendation. So a very simple example of a good practice statement would be conducting assessment before carrying out an intervention. Now, recommendations on your right are also action-oriented statements, but they are developed based on evidence from a systematic review. They answer a research question about whether an action or intervention should or should not be done. They are determined to be strong or conditional by considering the benefits and harms of the action. How certain we are in the evidence, the values and preference of people, and the impact on health equality. So we just look at all of those things to decide. And yeah. And in the following slide, we'll talk about strong and conditional recommendations in further detail. Again, what is important to remember, though, is both statements reflect best practice and should follow the same process for implementation. And this is my next one, right? The current slide gives you details to help you differentiate between strong versus conditional. So as mentioned, as on your left, the conditional, actually on your right, is the strong. Which one is your strong? Sorry, it's on the left. I'm getting a little confused. As mentioned before, good quality evidence equates to a strong recommendation. GRADE only considers randomized controlled trials or systematic reviews as high quality evidence may equate to a strong recommendation, depending on their quality and rigor. Low or very low quality evidence equates to a conditional recommendation. In general, GRADE discourages expert panels from making strong recommendations based on low or very low quality evidence. But in a strong recommendations, most people will benefit from the recommended practice. And I'll remind you that good practice statements should be interpreted as strong recommendations. And then on your right, conditional recommendations are not bad or less important. There is just a need to consider more carefully the individual's patient circumstances, preference, and values. Therefore, not everyone will benefit from the recommended practice. And then my last slide. So what you see on the slide is a simplified PRISM flow chart that indicates the rigorous process for the systematic review that the RNAO guideline team conducted for the recommendation questions. Our systematic reviews were aided with the help of a science librarian, and searches were conducted in 2022 and then updated in 2024. So to answer the research questions that inform the recommendations, we first screened 2,679 articles. Of these, 393 were full text examined. And finally, 23 articles were included. And this is across the 6 research questions. And each of the included studies were also quality of praise using the appropriate validated tools. More details on this can be found on our website under the methodology documents tab. So you'll see that on the website. And now I'd like to turn it over to Dr. Corey Hirschham.
Perfect. Thanks, Brenda. So I want to give you a bit of an overview for how to actually read the recommendations that you're going to find in the best practice guideline. So here you'll be able to find for each recommendation, you'll see a recommendation box. And within the recommendation box, this is going to actually outline the recommendation statement made by the best practice panel of experts. So the strength of the recommendation, the certainty of evidence effects, you will actually find noted within that recommendation statement box, as was outlined by Brenda, and how this will actually work and how you should be interpreting that. The recommendation box is actually followed by the discussion of evidence for each recommendation. So for each recommendation, you'll find 6 different components. So first, you'll find the benefits and the harms. So this section will just highlight some of the desirable and undesirable outcomes for the implementation of the recommendation that were found within the literature. You'll also find the values and preferences. So for this, it's going to go over the recommendation and the values that were placed on the health outcomes from the perspective of the person receiving the care. So for those individuals with a pressure injury or their family and their care providers. You'll also find the component of health equity. So this is going to be the impact that the recommended practice could have on the health outcome across different populations or settings, and some of the barriers that you may find when you actually go to implement that recommendation. You'll also find the justification of the recommendation made by the expert panel and why that recommendation was made. And then following the justification, you're also going to find some implementation tips on the how, who, what, where, and when related to actually implementing the recommendation. And then the sixth and last component is going to be the supporting sources. So this could include websites, any links, tools related to the intervention. So there's six good practice statements and six recommendations that are going to fall within three categories within this best practice guideline. They'll be broken up into foundational, assessment, and prevention and treatment. So the summary of the recommendations and good practice statements chart can also be found within the best practice guideline. And just due to time constraints, we're not going to be able to touch on all the recommendations and good practice statements found within the guideline today. But I'm going to be covering some of the key components that we felt would be relevant to discuss with the group that we're going to be meeting with today. But I would recommend, now that it's available, that everybody take a look through the guideline and read the good practice statements and the recommendations and see how they can be applicable for your area of practice. So the initial good practice statements that you see on the screen here provide the foundational recommendations for this best practice guideline. So the expert panel made three good practice statements. The first is that it's good practice for organizations to implement an interprofessional approach for the assessment, prevention, and treatment of pressure injuries. The approach includes shared decision making with persons at risk of or living with pressure injuries and their essential caregivers. The second good practice statement is that it's good practice for organizations and healthcare providers to communicate, and collaborate in a culturally safe and sensitive manner with persons and their essential caregivers in the assessment, prevention, and treatment of pressure injuries. And then the third good practice statement that you will find in the guideline is that it's good practice for health providers in collaboration with persons and their essential caregivers to use a systematic approach in the management of pressure injuries, which includes assessment, prevention, and treatment. And so we're going to go over a bit more about the second good practice statement today for the foundational component of the guideline. So, delivering care in a culturally safe and inclusive manner is part of good practice. Cultural safety is an outcome based on respectful engagement that recognizes and aims to address power imbalances inherent across the health system. It recognizes people and their families are active members in their care. And within pressure injury care specifically, there's disparities in pressure injury outcomes in individuals with darker skin complexions, for example. There's challenges in the early detection of pressure injuries due to darker skin tones, resulting in incidents of higher stages of pressure injuries in this population. And in a cross sectional national study in the United States, they actually observed longer hospital stays for those with people of color with pressure injuries. So in Canada, cultural safety and inclusivity in particularly important for the Indigenous communities whose member experiences discrimination, poverty, and exclusion, leading to disparities in health outcomes. So, the provision of culturally safe pressure injury management requires looking at that definition and understanding stage one pressure injuries and relooking at just how we oftentimes think of stage one pressure injuries as new redness in the skin, because that may be more difficult to notice in certain populations. So the expert panel determined that culturally safe and sensitive care was foundational to pressure injury prevention, assessment, and treatment. The expert panel determined the statement was necessary to communicate with nurses, and it's aligns with College of Nurses Code of Conduct, and the principle which states nurses provide inclusive and culturally safe care by practicing cultural humility, and therefore did not feel that this statement required a systematic review of the evidence. And moving forward, we'll also be talking about some of the recommendations in terms of how we can further address reducing some of the missed incidences of pressure injury development in some of these populations. So if we can head to the next slide, perfect. So the next section that I'm going to be reviewing is the assessment section of the guideline. So here you can see that there are two good practice statements as well as two recommendations. And we'll be going through recommendation one in a little bit more detail. But first, I just wanted to review some of these assessment components. So the expert panel came up with two good practice statements. The first is that it's good practice for health providers in collaboration with persons and their essential caregivers to use a multi-component approach during assessment and reassessment of the person's risk of developing pressure injuries. And good practice statement number 5 is that it is good practice for health providers to classify a pressure injury using a validated classification tool. The classification system shouldn't be used for monitoring pressure injury healing, and that's an important thing to note. The additional two recommendations is for recommendation number 1. The expert panel suggests that nurses and health providers use thermography as an adjunct to skin assessment for early detection of pressure injuries. And that brings us back to our previous discussion around those with darker skin tones and ways in which we can better assess that. And then recommendation 1.1 is that the expert panel suggests that nurses and health providers use subepidermal moisture detection as an adjunct to skin assessment for early detection of pressure injuries as well. So I just wanted to go into recommendation 1 a little bit more in depth. And that is a recommendation that has to do with utilization of thermography for detection of pressure injuries. So, considerations for skin tones are critical in terms of pressure injury risk assessment, as we recently discussed. Visual inspection alone isn't very reliable, especially in those with darker skin tones. So, because of that, looking at the presence of blanchability and redness may not be enough. However, in some instances, you are able to notice blanchability, redness, changes in sensation, as well as temperature and firmness before you notice any sort of visual changes in the skin. And thus, we can use certain instruments as adjunctives when we're looking at how we're doing our physical assessment of our patients who are at risk for pressure injuries. So, an over reliance, though, on that redness or the erythema in determining if a pressure injury is developing may be detrimental in determining whether or not pressure injuries are developing in darker skin tones. So, given that the panel prioritized the recommendation for this question on technology for early detection and assessment that you see in recommendation 1 to use thermography. So, for this recommendation, the intervention of interest was thermography as compared to standard of care. So, using no technology for early detection. So, for the purposes of this best practice guideline, infrared thermography, sorry, refers to the technology used to detect skin temperature by capturing infrared radiation emitted from the skin surface. So, the areas at risk for developing pressure injuries may have increased or decreased skin temperatures compared with those tissues around the developing wound site. So the expert panel noted infrared thermography may have increased utility in early detection of those with darker skin tones, and the technology may help to reduce a gap in identifying stage 1 pressure injuries and those with darkest skin tones and help to inform preventative care for patients who are more at risk. All right. And so the next section of the best practice guideline that I wanted to discuss is that in relation to prevention and treatment. So we have a number of recommendations and good practice statements for this section of the best practice guideline. The first that we're going to review is the recommendation 2.0, which talks about the expert panel's recommendation for nurses and health providers to reposition a patient at risk of pressure injuries every 2 to 4 hours. There is also a good practice statement that talks about how nurses and health providers should select an appropriate support service in collaboration with the person and their essential caregiver, and have provided some recommended factors to consider when doing so, including individual risk factors, contextual
The bike
factors,
is coming today?
personal preferences, as well as comfort. Recommendation 6 is the expert panel determined the current evidence was not sufficient to balance the benefits and harms of powered support surface compared to non-powered support surfaces. So the choice of support surface should really be individualized in these cases, and these should be in line with the good practice statement that had been mentioned when you're considering those four main factors of the individual factors, the contextual factors, personal preferences, and comfort. And then in terms of recommendation 3, the expert panel suggests that nurses and healthcare providers implement preventative care bundles for persons at risk of pressure injuries. There's 3 additional recommendations made by the expert panel as well for the best practice document. Recommendation 4 is the recommendation that nurses and health providers apply a multi-layer foam silicone dressing as a prophylactic measure for individuals at risk of pressure injuries, in addition to other preventative care strategies. So note that there's no recommendation that makes a recommendation for a single intervention. So these dressings should be applied to specific at-risk body areas, considering friction, shear, as well as pressure. The expert panel also suggested that nurses and health providers, in collaboration with the person and their caregiver, consider using negative pressure wound therapy for treatment of pressure injury if the person meets the indication and there's no contraindications present for that individual. And then the final recommendation for this section is that the expert panel suggests nurses and health providers, in collaboration with the person and their essential caregiver, consider using electrical stimulation for the treatment of pressure injuries if the person meets the indication and there's no contraindication. So, in the next few slides, I just wanted to talk about 2 recommendations from this section on prevention and treatment. Recommendation 2 and 3, which is the recommendations for turning and positioning the patient every 2 to 4 hours, as well as the recommendation for nurses and health providers to implement preventative care bundles for those at risk. So, recommendation 2 refers to turning individuals to change their body position in order to relieve or redistribute pressure. And positioning the patient, the idea is that it reduces tissue hypoxia over top of an area of bony prominence, or if the patient is over a medical device, as we discussed earlier, for example. Repositioning has been a real fundamental component of pressure injury prevention, as I'm sure many of you know, and repositioning reduces the amount of pressure over the tissues, um, providing that theoretical risk reduction for pressure injury development. The expert panel had made note that there is a number of benefits to repositioning and preventative care in terms of injury incidents and pressure injury precursor signs and symptoms at both the 2 hour time period, the 3 hour time period, as well as the 4 hour time period intervals when compared to 5 or 6 hour repositioning. No actual harms were reported within the literature. However, the certainty of the evidence that we found during the review was quite low. There was also individual factors to be considered when planning and tailoring positioning. So, given that the expert panel determined the strength of the recommendation was conditional. So, 3 randomized control trials had actually found the evidence is very uncertain whether a 2 hour rounding schedule compared to a 4 hour rounding schedule had decreased the pressure injury incidence, which is where you're seeing the expert panel recommendation for turning and positioning that patient between every 2 and 4 hours. And then we get into recommendation number 3. So, for this recommendation, the expert panel had suggested that nurses and health providers implement a preventative care bundle for persons at risk of pressure injury development. So, this intervention looks at not determining patients' individual risk or how to treat it based on one singular intervention alone. Um, and we compared in the systematic review the idea of a single intervention as standard of care versus the implementation of a care bundle, such as, for example, the SKIN bundle that you see to the right of your screen. The purpose of the best practice guideline, for the purpose of the best practice guideline, preventive care bundles refer to a group of evidence based interventions that can ensure standardization and delivery of care across multiple groups and individuals. And when the interventions are performed together, they result in a better outcome versus individually. And depending on the care bundle that you're implementing, these can be things like ensuring the patient's mobility, turning and positioning, ensuring proper nutrition, hydration, that kind of thing. So the bundles were included if they were an integrated set of 2 or more interventions implemented together rather than a singular intervention alone. So the um, expert panel emphasized a person centered approach and recommended tailoring strategies within the care bundle to that individual. So, making that care bundle applicable to the individual that you're caring for by seeing which sections of the care bundle are applicable to the patient that you're caring for in collaboration with that patient as well as their caregiver. The expert panel emphasized the importance of preventive care bundles for those with darker skin tones, or in those individuals or greater populations of those with greater or with darker skin tones, sorry, given the increased chance of missing those early signs of pressure injury formation that we had discussed previously. The expert panel noted there may be benefits to preventive care bundles for preventing the incidence of pressure injuries, as well as preventing those precursor signs and symptoms like redness and some other instances like the changes in temperature, for example. No harms could be found within the literature with regards to the implementation of these bundled packages. However, the certainty within the of evidence within the literature remains quite low, and therefore the strength of the recommendation was conditional. And that covers the key recommendations that I wanted to discuss with you at this time. So I will turn it back over to the RNAO team to continue the presentation. Thank you.
So now it's time for a break. We would say 5 minutes, and if you go a little longer.
So I will actually
Oh,
just
sorry.
let everybody um, know that we're actually going to move into a quick 10-minute break. After which we will be going back to the RNAO team to talk a little bit more about how the pressure injury best practice guideline is actually going to be implemented or could be implemented in your practice, and how some key ways you can look at the implementation of this guideline could help to emphasize within your practice setting. So thank you so much, everybody.
And then we'll get started again. Thank you. So, hi everyone. I'm Catherine Wallace. I'm Senior Manager and part of the Implementation Science team, and my pleasure to be participating in this wonderful Pressure Injuries BPG webinar. And so great to have, I see 122 participants. That's amazing. It tells us that this is a guideline that is meaningful to so many of you. And as I saw as you came into our presentation, that many of you from across multiple sectors, and that's great. It's exciting to think about all of you reading this guideline and then thinking about how you can adopt and integrate these recommendations and good practice statements into your organization. So let's talk a little bit about kickstarting your implementation of the PIBPG. Thank you. Thanks, Lindsay. So for this section, I want to describe 5 actions to kickstart our implementation of this guideline and appreciating for some of you that this is new. And for many of you, though, we know that this is a guideline that you have used historically. So maybe you're familiar with our first, second, or third editions of the pressure injuries BPG. So we welcome you today and hope that you will find this new 4th edition useful for your practice as well. But let's start thinking about if we are going to implement this new edition and or be reviewing it through the lens of a continued end user of pressure injury best practices. So a couple sources of knowledge I just want to acknowledge before getting started. And that is first our Leading Change Toolkit. This is our implementation online resource. It's available free to anyone. And it's written for any kind of champion or change agent or a member of a change team that wants to make a lasting improvement in healthcare. And that absolutely includes pressure injuries, assessment, care, management, that Brenda and Corey have described for us earlier in the presentation. So helps us to think about how can we actually make best practices, what's involved in that. And to that, then, we think about in our Leading Change Toolkit these 2 frameworks that focus on the people and the process of making change. What do we need to know in order to successfully adopt and integrate best practices in pressure injuries? And that includes understanding that people need to be actively involved and engaged in this process. And for that, we have our Social Movement Action Framework, a framework that describes a people led approach to change. The best change is made, we know, with and by people, not to people. So, how can we do that? How can we have staff actively involved in the change process? And the Social Movement Action Framework gives us some insight into that. And in our Leading Change Toolkit, you'll find lots of details on that. And then, in addition, we need to know how to actually plan, make, and sustain change. And for that, we use our knowledge to action framework. This describes in 7 action cycle phases how we can do just that. And both of these frameworks, they're evidence-based, based on a concept analysis to be able to understand these concepts and provide us then with a comprehensive approach to change that includes and emphasizes the people and the process. In addition, and something newer for us at RNAO is our Best Practice Champions Competencies Framework. So this addresses what do we need as change agents, as advocates for change, as members of change team, what skills, what knowledge, what attitudes, what behaviors do we need in order to be effective in our role? And so we did a review of competencies for champions based on a scoping review and identified 7 different roles that champions play. We'll highlight those a little bit in this part of the presentation, but wanted to make you aware that we have a best practice champions competency framework that can be really helpful for implementing guidelines, including this new pressure injuries guideline. Okay, and to this end, then we also have our blended learning series. This is a newer offering now for the past year, includes a 4-part or 4 modules in this learning series, 2 that are completed online and then 2 that are live sessions. So we offer these on a monthly basis. If this is of interest to you, we'll have another series running in December and beyond, but really helps us to better understand how can we do our best to implement a best practice guideline and be a true advocate for change as a champion. And then included in that are these job aids. This we have in our resource library, and these address different components of implementation, different challenges we may face as champions of change as we navigate this process. And I'll highlight some of those today. If you access this content as a champion, then in the resource library, you'll be able to access any of these job aids at no cost. Okay, so let's talk about 5 actions to kickstart implementation for new and again for returning end users. Again, recognizing many of you have implemented the pressure injury guideline over many years. And a key takeaway here is that we can't simply read a guideline, although you'll see that is my first recommendation to you. We need then to take active steps. So let's talk about actively reading the guideline. We'll think about it in contextual factors and their impact in making practice changes. We'll think about receptivity or readiness for our teams to make change. Talk about a change team briefly, and then completing a gap analysis. Okay. All right. So the first thing is about actively reading the guidelines. So we're hoping that in attending today, you're hearing about the guideline, the good practice statements, the recommendations, the appendices, so much content that's available to us. And so beyond listening to this recorded presentation, then also to read the guideline and really actively reading the guideline, maybe thinking about how will we make these practice changes. Something that's important then, as we read the guideline, and to recognize this is a skill, to be able to understand a summary of evidence that has been formed as a result of a systematic review and a quality appraisal, and be able to read that discussion of evidence and say, what does this mean? So to be a good meaning maker or sense maker, say, what does this mean in terms of best practices? What's current best practices as defined by this new BPG? And ideally, in doing that, also convey a positive attitude regarding best practices, to be excited about making practice changes or augmenting your current best practices based on this 4th edition. So, someone who can do this, we define as one of our competencies of a champion. They're a content expert, somebody who has the skill, the ability to read a BPG and say, this is what it means, and be able to convey that to others. And sometimes others have challenges with reading evidence, understanding what that means. And so being able to actively read a BPG is a skill and something that's essential if we're going to make a practice change. And in reading the guideline, also, you might also start to think about what are some possible practice changes as well. So lots of contributions that our content experts make as far as implementing this BPG. Now, if reading a guideline is new for you or something where you'd like to kind of brush up on your skills, we heard Brenda talking about grade methodology. If that's new for you, then approximately a year ago, as part of our Best Practice Champions information sharing series, we had a presentation by our guideline development team on how to read, use, and interpret a BPG. Not specific to pressure injury, as you can see, it was recorded a year ago, but nonetheless can be very helpful if we're developing the competency in being able to read a guideline and again, be that meaning maker or sense maker that really kickstarts being able to implement a BPG. So make you aware of that. That's available on the RNAO YouTube page. And then in addition, a couple of other sources of information that can help us when we're reading the guideline, really beginning to think about making practice change. So one section beyond the discussion of evidence is the implementation tips. You'll find these throughout the new edition of the PI BPG. And these come to us from the expert panel as well as from evidence. And it gets us thinking about real world practice changes. What does it mean at the point of care or wherever it is that we're implementing this BPG? So to make you aware of that, if that helps you to better understand what is this recommendation about, what would this practice change look like when we're actually making the practice change? And then finally, if you're still struggling with understanding the guideline or have questions about the implementation, or as my colleague will discuss next, about evaluation and monitoring, we have a contact us at RNAO. We want to be accessible to anyone using our BPGs. So please use that, reach out. That's another way of getting any questions regarding our guidelines answered. Okay, so we've read the guideline, and something that's very important for us to remember is that the guideline was not written specifically for you or your sector, even. And again, I noticed the range of sectors that are present today. We've got people joining us from home care, from acute care, et cetera. So we need to think about as we read the guideline, what does it mean for us? These recommendations, these good practice statements. When we think about it in the context of the staff that we have, the persons, the patient population, again, the relevancy of these good practice statements and recommendations, and whether or not any adaptations are needed. Ideally, an organization or a unit, a team would adopt all of the recommendations entirely as written in the BPG, but sometimes we need to make some small adaptations in order for it to make sense for the staff that we have, the people that we provide care to. And this, again, another one of the competencies of our champions is that of a context expert. Somebody who really thinks about what does change mean for us? And to remember that the guideline, not specifically written for you, but we need to make sometimes some small adaptations in order for it to be most meaningful. And then to this, again, we have a job aid, and this is part of our blended learning series about adapting a guideline recommendation or good practice statement to your local context. Again, first read the guideline and then ask yourself, will we need to make any small modifications as per the discussion of evidence, the implementation tips, etc.? And if so, then this resource can be very helpful. Thanks. Okay, so the next one is about when we make change, we need to think about the people involved in change. Again, we ideally want to make change with people and not to people. And so part of that also is thinking about their receptivity or their readiness for change. We need to be mindful of things like how much change is already happening in our organizations. Do we have the time, the resources available right now to implement this new guideline? And again, I see so many of you on the call joining us today. That's really exciting. We want you to read the guideline and get started thinking about making practice change, but always being aware of how much change can we make at one time. And when we make a practice change, we really want to do it to the best of our ability. And part of that also is just thinking about, are we ready to do it? Is this the right time for it? So some variables that will enhance this is, for example, is the change seen as valued and needed by staff? That's according to our social movement action framework. And if it is, that can be a positive driver for change and something that makes us more ready for change. The timing, again, just think about how much is happening in our organization right now, and have we just got enough right now going on, or are we ready then to make more change and adopt this BPG? Um, Another factor that can make us more ready for change is just that we have some visible leaders for change, and that includes our senior leadership as well as our frontline staff. And them having that visibility, talking about the BPG and talking about making change and being excited about that. Having recommendations that work and are workable, ones that will address and identify concern in your organizations, and one also that is workable or feasible. It's something we can actually achieve and achieve right now. Again, results that we see as being something that's doable in the current situation. And then having the necessary resources, and that can include many things, including having available budget and then also having available champions. And again, we offer our champions training on a regular basis. And this recognizes, again, one of the other roles of champions and their competencies, and that is being an advocate for best practices. So, yeah, when all of these variables are present, then it makes us more receptive or ready. It acts as a precursor for taking action. And when we have that readiness for change, then we're ready to address our practices and see where we need to make any edits, any changes, and then update our practices to align with the new edition of this BPG. Okay, and then in terms of receptivity to change, again, we have a job aid on this that you'll find helpful in our blended learning series. Again, thinking about things like, is there motivation? Are people interested in making changes to their pressure injury practices? We hope so, and we hope that this BPG will drive that. Do we have the resources present? What else is happening in your organization, et cetera? Just being mindful of the bigger picture when we're looking at making a practice change. And then assembling a change team. We need a small group of individuals to guide and lead the change process, to guide and lead people through change. And we want those individuals who have an enthusiasm and excitement for pressure injuries and bring subject matter knowledge. We want individuals who know how to read the guideline. And in addition, we want those individuals to be leaders as well as mentors, those who can help support others through the change process. But just recognizing it's people who make change, and we need to have a small group of people to guide and lead us through this process. And we have lots of resources on supporting change teams. They have big job to do. They need to work well together as a team, as well as work well with staff in order to have a successful practice change. And so to that, then we have a job aid that's part of our blended learning series. And then also in our leading change toolkit, we refer to change teams as core leadership structures, and you'll find lots of information in that resource, again, freely available. And then this is my last point for kickstarting BPG implementation, probably the most important one, and a job typically started by the change team, which is to complete a gap analysis. So this is when we're doing the comparison of what's our current practice in pressure injuries, and then what does the good practice statements and recommendation statements, what do they say? And then doing a comparison. Are we aligned with best practices, or do we need to make some small or big changes? And the gap or opportunity analysis determines that. And it'll tell us where we're aligned with best practices and then where we need to make some practice changes. So, again, lots of information you'll find in our blended learning series, as well as in our leading change toolkit. Again, typical work that's done by our change team and reflects champions' competencies of being good collaborators, working together and working with staff, and also good facilitators that they're starting to operationalize practice change. Really think about, okay, what are we actually going to do in order to achieve best practices? And I think that's the end of my section. As part of implementation, always includes evaluation and monitoring. And for that, I will hand it over to my fabulous colleague, Dr. Christina Medeiros.
Thank you so much, Catherine. And as Catherine mentioned, not only are we looking at implementation, but also understanding the impact of implementing this very important guideline. So next slide, please. So these session objectives for this part of the session is really to understand how indicators are developed at RNAO, learning how to select indicators based upon prioritized good practice statements and recommendations, using the gap or opportunity analysis that Catherine had discussed, as well as recognize when to start monitoring and evaluating the impact of VPG implementation and gathering team members, and also learning how to develop a logic model. Really according to that completed gap analysis and understand the importance of sharing data. So let's hop to it. At RNAO, our indicator development process is a fulsome six-step process. And I'll give you a bit of an overview of it. So our first step really includes that guideline selection, where indicators are developed for BPG such as this one. And the next step is extraction of recommendations. So in this step, the drafted practice recommendations and good practice statements, as well as overall, research outcomes and previous editions of the BPGs are reviewed to really extract those potential measures for indicator development. And then we move on to our third step of indicator selection and development, where we actually go ahead and draft the process indicators, which are aligned with good practice statements and recommendations of the BPG, as well as outcome indicators, which are aligned with the outcomes of the research question. And when we really develop these indicators, we really understand, whether it meets certain criteria, such as, is this relevant to measure, if this is feasible to measure, if this is usable to measure, and if the measure itself, the indicator that we've developed, if it's readable and understandable to measure. And we also go about aligning these indicators with external organizations to really ensure that we're adhering to a collect once, report multiple times principle. So if you're collecting on a certain indicator, we want to make sure that organizations who are collecting on, for instance, risk assessment for a pressure injury, that if you're collecting on it for this particular guideline, that you can report it to multiple organizations that you may be needing to report to. And then we have our practice tests and validation. So we send our indicators for 2 rounds of validation with our expert panel, as well as our external validation. So we send these indicators out along with the drafted BPG to our external reviewers as well. And we gather this quantitative and qualitative feedback and integrate it with our team and some members of the expert panel to really make sure that these indicators meet the criteria for collection and data submission. And then now we are at step 5, which is implementation. So we are developing the data dictionary, and we've published these indicators in the BPG and the BPG evaluation section, which is very, very exciting. And we also develop data dictionaries, which are documents that are housed in our NQuire, our nursing quality indicators for reporting and evaluation data system, which really tell a bit more of a fulsome story about the indicators, looking at inclusion, exclusion criteria, and giving a bit more guidance to organizations who are part of the best practice spotlight organization program in collecting and submitting data for these indicators. And then in step 6, our monitoring and evaluation team really undergoes data quality assessments and evaluations to look at, the usability of these indicators to determine whether they should be carried forward into next edition BPGs, which is part of the process that we did for this BPG as well. Thanks, Lindsay. So evaluation really is often thought of at the end of a project or initiative, but really we want to think about evaluation at all stages of implementation, before, during, and after implementation of a best practice guideline in a practice setting. It's really important to monitor the use of the new BPG good practice statements and recommendations that are introduced and evaluate the outcomes or the impact of the resulting change in practice. So we really want to think about evaluation at pre-implementation, implementation, post-implementation, and into sustainability. And as part of this process of thinking about evaluation and the evaluation plan is really to identify your evaluation team. And so really at the center of your evaluation team is that BPG implementation lead. And this really coincides with what Catherine was talking about, right? Having that fulsome team that can really assist you in implementing and evaluating the impact of this BPG. And so it's really important to engage people with, some sort of clinical experience, leadership who understand how these changes that are made will affect clinical care processes. And engaging frontline staff like nurses or other members of the interprofessional team and gathering their feedback really help to identify how these care processes are being affected or the impact on persons that are receiving care, since they're the ones that are implementing the changes and may also be collecting this data. It's also important to engage senior management or project sponsor, someone who really has that executive authority and can champion the quality improvement project, and also assist with getting resources, perhaps overcoming barriers when implementing improvements. And sharing these results from the evaluation really helps senior management to influence those policy changes as well as organizational changes to scale up that implementation. It'll also be helpful to have support from people with technical expertise. So those people who understand quality improvement processes, how health information technology systems work to really support the proposed practice changes. So some organizations may have decision support specialists or even clinical informatics and other IT staff to help with standardizing electronic documentation, identifying data sources, data extraction from electronic medical records, among other things. And of course, not all organizations have this support and maybe using paper documentation. In that case, some of these important members may take on multiple roles in data management. And then we need to include individuals who exhibit day-to-day leadership, like professional practice leads, to ensure that there's completion of tasks such as data collection, analysis, and change implementation. Next slide, please. Yeah, thank you, Lindsay. And then we go into our selection of indicators. So this is also a fulsome process whereby we first identify the best practice guideline. And so with respect to that, this is the pressure injury management, risk assessment, prevention, and treatment guideline. And then we conduct that opportunity or gap analysis, as Catherine had mentioned, to really identify those practice recommendations or good practice statements to implement. And then we consider those feasibility, organizational priorities, and reporting requirements. So really thinking about, does this align with other reporting requirements that you may have to other organizations in terms of selecting those indicators to really ensure that you're minimizing that reporting burden. And then of course, selecting indicators that align with BPG recommendations, and also considering that level of implementation. Is this guideline recommendation or good practice statement being implemented at specific units or parts of your organization, or will it be implemented throughout your organization? So different types of considerations to take into consideration when selecting indicators. So perhaps we completed that gap analysis and we selected this good practice statement 3.0, which is it is good practice for health providers in collaboration with persons and their essential caregivers to use a systematic approach in the management of pressure injuries, which includes assessment, prevention, and treatment. So now that we've conducted that gap or opportunity analysis, we have a selected good practice statement. We're going to create that evaluation plan. And so this evaluation plan really sets out the details of an evaluation that would reflect, what will be evaluated, how and when. And so this is really like a roadmap. And this evaluation plan really shows the route traveled or steps taken to reach a certain destination. And it identifies both the processes used and outcomes to be achieved, and identifies how success will be measured. And so these evaluation plans are not usually created in one sitting. And so people involved in creating this project really initially brainstorm and map out those preliminary evaluation plans. And others would be involved, such as staff that could be consulted to refine this plan. So here's an example of a logic model or evaluation plan on the screen. And so we're going to focus on that good practice statement 3.0. And so here you can see on the screen in blue, these are inputs. And so these are the resources needed for the project. They include, education materials, funding, professional practice lead, among other different types of resources. And the next in orange are the activities. And so these are the activities that will be carried out as part of the project. So some activities may include, perhaps conducting educational workshops about how to conduct this assessment of pressure injuries. Perhaps creating pocket cards for nurses and other health professionals, and maybe even update documentation to include that assessment tool for pressure injuries. And then we have outputs, which are products that are produced from the activities. And so they usually provide a numeric value or attributing percentage. So this could perhaps include a number of nurses trained or health professionals trained, whether the flow charts were updated with this new assessment tool, and whether it was integrated in the electronic medical record. And then you have your outcomes, which can be short-term or long-term, and are associated with changes in knowledge, awareness, behaviors, and skills. So here we can see that we have increased awareness and knowledge and increased use of that assessment tool. And the long-term outcome is improved healing of pressure injuries, given that there's an increase in the percentage of persons with a pressure injury who received a pressure injury assessment. So you can see the corresponding process indicators and outcome indicators, which you can find in the BPG evaluation section of this BPG, that will help measure the knowledge use and outcomes. And these are both circled in red. And so we know that knowledge is really a critical element in understanding whether clinicians understand, accept, adhere, and apply evidence-based practice recommendations and good practice statements. Monitoring and knowledge use really helps answer the question, are these recommendations or good practice statements being used? Is the implementation intervention working? So during the implementation phase, you're monitoring knowledge use to really provide insights on the rollout of implementation activities and changes. So there's two types of knowledge use that you can measure, which include conceptual knowledge use and instrumental knowledge use. So conceptual knowledge use is really that knowledge that describes a practitioner's understanding and internalization of knowledge and information. And so you can really measure this by administering perhaps a knowledge test before and after an education session on conducting those assessments to really see whether participants understand or whether they've learned the evidence supporting this good practice statement. And then we also have instrumental knowledge use, and that's a knowledge that has been applied in practice and as a result of influenced behaviors or actions. And this is really the application of knowledge. And you can measure this by doing a chart audit to determine if the assessment tools are being used. And so another aspect of evaluation is really sharing that quality improvement data. And so there are a number of different reasons why it's important to share your data. First, it really helps others understand the impact of evidence-based practices on outcomes. It's also an important way to engage with your staff, those who are making those changes. So we've heard from many organizations time to time that it can really be rewarding for staff to see those positive outcomes and differences that they're making on the quality of care. And at the same time, it can be very motivating when you show data that indicates a gap in care or a need for improvement and really seeing those improvements actually happen and being sustained. And so it also allows for rapid learning and feedback and wide-scale spread of best practices and improvements. And most importantly, having access to data in daily practice is really crucial and critical in understanding gaps in care, which allows us to learn and improve the care that we provide to persons and families and their support networks. And in some ways, also care for our staff. And so if you're sharing data for quality improvement in your organization, you can also improve not only the care that you provide to persons, but also your staff and your organization, and also improve the health system as a whole. So really, once you've done all this, the next steps are, considering your implementation and evaluation team, really conducting that gap or opportunity analysis, selecting those indicators, developing that logic model according to the gap or opportunity analysis, developing that plan for standardized data collection, and beginning that baseline data collection. And so now I'll pass over to Glynis to facilitate our question and answer period.
Perfect. Thank you, Christina. So just before we begin the question and answer period, we just wanted to share with you all that the BPG is now freely available for download on the RNAO website listed on the screen. So if you have any other questions regarding the guideline, please feel free to contact us via our website, or you can also contact myself, Glynis Gittens, at ggittens@rnao.ca, and you will see my email also listed on the screen. I also just want to give everyone a few more minutes if you would like to scan the QR code from your phone to also access the BPG. So just as you all scan your phones, I just wanted to note that this brings our webinar to an end, and we would like to thank you all again for taking the time out of your day to attend. We hope that it was a great opportunity for you to learn more about RNAO's newest edition of the Pressure Injury BPG. I will now stop the recording, and then we will begin the question and answer period.